Today's topic is surgical treatment options for localized prostate cancer. My name is Andrew Wood, and I'm a Urologic Oncology Fellow at Cleveland Clinic, and I'll be moderating tonight's session. I'd like to extend a warm welcome to all of our audience participants and invite all of them to submit any and all questions via the live chat Q&A. We will try to get to as many as we can throughout today's Q&A session. So without further ado, I'd like to introduce our three prostate cancer expert panelists. The first is Dr. Jihad Kayuk. He's a director of the Center of Advanced Laparoscopic and Robotic Surgery here at Cleveland Clinic, also director of Fellowship for Robotic and Image-Guided Surgery. He has an endowed chair in laparoscopic and robotic surgery, and he's the vice chair for surgical innovations here at Cleveland Clinic. He will be joining us shortly. He's running a little bit late in the operating room at the moment, but he should be here soon. Our second panelist is Dr. Samuel Haywood. He's an associate staff in the Department of Urology here at Cleveland Clinic. He's a fellowship-trained urologic oncologist, meaning he's an expert in the diagnosis and management of all genitourinary cancers, including prostate cancer. And our third panelist is Dr. Ruben Olivares. He's also an associate staff here in the Department of Urology at Cleveland Clinic. He's fellowship trained in advanced laparoscopy and robotic surgery, and he has a special interest in focal therapy, including focal 1, focal HIFU. So I'd like to kick off the discussion tonight with some brief words regarding prostate cancer incidence, screening and diagnosis. Of note for all in attendance, the prostate cancer screening and diagnosis official discussion will be tomorrow night starting at 5 p.m. So how common is prostate cancer? Well, it is the most common prostate cancer in American men. 1 in 8 men will be diagnosed with prostate cancer in their lifetime. If detected and treated early, the 5-year survival rate is excellent. So with that in mind, prostate cancer screening is a tool that we urologists use to try to detect prostate cancer at an earlier stage because studies have shown that it does lead to, the prostate cancer screening does lead to earlier detection and can improve survival. So what does prostate cancer screening consist of? So it's an annual PSA blood test and physical exam. Who should get prostate cancer screening? So depending upon which professional society guidelines you consult, for men of average risk prostate cancer screening should start between ages 50 and 55 years old. For patients of a higher risk of prostate cancer, such as those with a first-degree relative with prostate cancer, guidelines suggest starting screening in your 40s. So what's a concerning result? This is a common question from patients. So the general rule is a PSA of over 4 would warrant further investigation, including a possible biopsy. However, this is a pretty general rule as PSA cutoffs are dependent upon both age and size of the prostate. If you have any additional questions regarding prostate cancer screening, I encourage you to talk to your doctor about potential benefits or tune into our discussion tomorrow at 5 p.m. Okay, so before we get into discussing prostate cancer management options, we have to discuss how men are initially worked up with prostate cancer. So we already discussed PSA screening, and the vast majority of prostate cancer in the United States is diagnosed as a part of PSA screening that leads to a prostate biopsy and then provides us some information from that biopsy, including Gleason grade group that you may have heard of, which allows us to, with other factors, risk stratify patients into 3 categories that affect how we're able to, which different treatment options we're able to offer. And that's low risk, intermediate risk, and high risk. Dr. Haywood, would you mind explaining a little bit more about Gleason grade group and how that allows us to risk stratify patients and how that affects what kind of management options we offer?
Sure, and thanks for that great intro and overview. So one of the first things that your doctor will probably talk to you about after diagnosis is the risk stratification. So there's a couple ways that we talk about this. One is the Gleason grade, and that tends to be a little bit of the older scale that we use, but a lot of patients still discuss it, and so I'll at least bring it up in brief. And that scale starts at 6 and goes to 10, whereas more recently, we've been trying to use the grade group scale, which goes from 1 to 5, and we find that that's a lot easier for patients to understand and digest. A simple scale that goes 1 to 5, and so based on based on that grade group, and then also the number of cores that are positive, patients can get categorized into their risk categories. So we define them as low risk, intermediate, and high risk. And so patients that are low risk are going to be those that have either a Gleason score of 6 or a grade group of 1, whereas the Gleason score of 7 or grade group 2 or 3 will fall into intermediate risk. And anything above that will fall into high risk. So that's the grade group of 3 or a Gleason 8 through 10. And so the kind of further evaluation with staging imaging or the treatment options are all taken in that context of these risk stratifications.
Thank you very much, Dr. Haywood. So starting off with patients with low-risk disease, there's a couple pre-submitted questions that we have here regarding treatment options or management options for grade group 1, including one patient that asked essentially, why do some prostate cancers not need to be treated, and bring up the topic of active surveillance and whether does that mean that the cancer will never require treatment, or might it need treatment later? Dr. Olivares, would you mind just describing active surveillance and which patients are eligible for active surveillance, including is there any patients with grade group 2 that might be eligible, and what it entails? Is it just watching, or what do we do, and sort of the triggers for treatment?
Yes, perfect. Thank you. And thank you for the question. As Dr. Haywood said, not all the prostate cancer are the same. The PSA is produced by normal prostate. Most of the people, and probably the people that are attending this meeting, thinks that the PSA is produced by prostate cancer. There is not. Normal prostate produce PSA. If you have just a small hole in the external capsule of the prostate, the PSA can spill it into the blood and raise the blood test. If your doctor see that, probably it's going to take a biopsy. And the biopsy, not all the finding from the biopsy is going to be the same. If you have a cells that is defined malignant, but it's like lazy, meaning that instead of eating all the surrounding tissue and invading the surrounding structure and try not to go to do metastatic spread, we are talking here about low-grade prostate cancer. To make the things easier, as Sam said, instead of calling Gleason 6, that start from 6, we use now grade group 1. When you have this diagnosed, first of all, you have to be completely confident is that this is all the cancer that you have. When you take a biopsy, you take just a few samples, just a few millimeters of your prostate tissue. For example, if you have a prostate of 80 grams, that that it's a matter of aging, the prostate getting large, with the prostate biopsy, you are going to take roughly 2.5 grams of tissue. So the first thing that you have to be aware that probably you are going to need a confirmatory biopsy, meaning that you have to sample the surrounding tissue to be completely sure that we are not missing more significant cancer. Nowadays, the better way to do that is asking for an MRI previous the confirmatory biopsy. Because, for example, with the digital rectal exam, you just feel one side of the prostate. With the biopsy, you take a few millimeters of tissue. With the MRI information, you can see everything that is happening, and probably it's going to guide a new biopsy with probably new findings. But if you are totally sure that it's a low-grade prostate cancer, active surveillance, meaning it doesn't mean don't do anything, means that it's a close monitoring of what is happening there. With that, you can ask for example, genomics, to see if even though you are talking about low grade according to Gleason, the histology of the prostate, you are going to need more treatment. Short answer, in patients with low grade cancer, as monitor confirmatory biopsy to make sure that it's only a cancer that you have, because probably the patient that has that kind of cancer is not going to die. For example, all the data out there shows that after 15 years, from 15,000 patients, 1 or 2 is going to die from prostate cancer. So monitor the disease is pretty safe.
Okay, yeah, thank you very much for that, Dr. Olivares. And you did mention genomic testing, and we did just have a question come into the chat regarding Oncotype DX. So I think it's a good opportunity to discuss genomic testing in general, as Oncotype DX is one of the genomic tests. Dr. Haywood, could you explain a little bit more about the genomic testing that we do and how that affects our treatment decisions?
Yeah, that's a great question. So thanks for submitting that. Genomic testing is something that's come about in the past few years. And what it does is there's a couple of different ones. There's Oncotype DX, which the question was about, but there's also other tests like Decipher out there. And these tests are commercial tests that are run on the prostate cancer biopsy specimens. And what they do is they look at the genes that are turned on or off in the cancer tissue. And by looking at that information, they can produce some data and score that you can use in conjunction with your doctor to try and understand what's truly the biologic behavior of the cancer. So the way I try to describe it to patients is we're looking for the wolf in sheep's clothing, in that is this a cancer that looks less aggressive on the pathology, but is destined to become something more aggressive. And so I think those tests can be helpful in certain circumstances. I don't order them on everybody, but certainly for patients who are considering active surveillance and they want some additional help in leaning whether active surveillance is safe or if they might be better served by a definitive treatment strategy, they can be very helpful.
Fantastic. Thank you, Dr. Haywood. Dr. Haywood mentioned definitive radical therapies for localized prostate cancer, which of course the topic of this talk is surgical treatment options. So the standard surgical treatment option is of course a radical prostatectomy. Dr. Olivares, would you mind talking a little bit about radical prostatectomy and how it's most commonly performed nowadays, and what patients can involve with that surgery, and which patients are candidates for it?
Yeah, sure. The first thing that I think is very important to clarify surgery is that the patient, as a matter of aging, can develop 2 main conditions. One is the prostatic enlargement. That is from the medial part of the prostate. With that, you're gonna hear acronym like TURB, transurethral resection of the prostate, that you can use laser, different things. That goes from benign hyperplasia. That goes from benign enlargement of the prostate. When you have prostate cancer, it's mostly from the external part of the prostate. So scrapping the prostate is not an option. It's not a curative option. You have to remove the prostate completely as a whole. The prostate, with the seminal vesicles, the entry of the vas deferens, and probably the lymph nodes that are taking care of the prostate. That we call radical treatment, completely removal of the prostate. The problem is that the prostate is seated in the pelvis, in the narrow pelvis, with the rectum very close, the bladder above. So it's not like an easy anatomical place to work. That's why after many years of development, nowadays we have robotic surgery. Robotic surgery is the concept like the master slave, with a surgeon seated in a console, move the arms, and the robot reproduce the movement that the surgeon is doing in the console. And why is that? Because even though you can have a very advanced with a lot of skilled surgeon, the place is not very friendly to receive that kind of surgery. Secondly, it's a better visualization with the scope that the robot has. You can go in pretty close with the structure. So if you see better, probably you are going to have a better outcome. Third, that even though your doctor didn't drink a lot of coffee that day on the morning, you have physiological tremor. The robot does not have that. And finally, the 3D visualization give you more deepness conditions, so you know better when you put the stage of that sort of things. But I just want to highlight the fact that the experience of the surgeon plays the most important role in this discussion. Even though at the Cleveland Clinic we have the more advanced surgeons with the very good outcomes, how confident your surgeon is offering you the best alternative for you must be the most important fact. If the surgeon thinks that open approach with a knife is the best way for you, probably it's going to be the best advice. But robotic surgery got a lot of advantage. Everybody knows the side effects of radical prostatectomy, especially urinary incontinence and erectile dysfunction. But if you see better, probably you're going to be able to preserve that important functionality of you.
Fantastic. Thank you very much, Dr. Olivares. So you mentioned side effects from radical prostatectomy, and of course, radical prostatectomy being offered mostly for intermediate and high-risk prostate cancer. And of course, there's several other options available for intermediate and high-risk prostate cancer, including different radiation options. And there's been a few questions submitted regarding all the different options available for these intermediate and high-risk patients, and how and what the side effects might be, and what the differences might be, and how to make a decision, and how difficult that can be to try to make a decision with so many different options. Dr. Haywood, would you mind just describing a few of the other options available for whole gland therapies for patients, and some of the expected side effects with both radical prostatectomy and the different other whole gland options, and just give a little bit of insight into how patients might be able to sift through that?
Sure. Yeah. So the the other options besides for radical prostatectomy would be radiation options. And so when I describe it to patients, hey, there's two main options for radiation. There's an external beam radiation where you go to a radiation center every day for a number of weeks, and they focus radiation energy on the prostate to treat the cancer. The other option is seeds or brachytherapy, and that's a one-day procedure where the radiation oncologist and the urologist together implant radiation little pellets, like the size of like a piece of rice, into your prostate. And those seeds stay in, they don't ever come out, and they release radiation energy over time to treat the prostate cancer. Now, those options, they're can be thought of as a little bit less invasive, and they have different side effects. And so the side effects that those patients can get, tend to be more, bother from a urinary and a bowel standpoint. The bladder and the rectum are the two organs that are right next to the prostate, and so there's unfortunately no way to get radiation 100% directly to the prostate, and so the bladder and rectum can get some of that radiation energy, and when that happens, they can get some irritative symptoms. So some frequency, some urgency of both urine and bowel, occasionally some bleeding, that sort of thing. And those were what I would say kind of the main other whole gland options besides surgery.
Okay, thank you very much, Dr. Haywood. So another pre-submitted question was regarding the possibilities of the focal one therapy that we have available here, and possibly just the idea of focal therapy in general, and who might be a candidate for that, and what it consists of, and what to expect for patients. Dr. Olivares, could you give us a little bit of a background on how focal therapy has sort of come to be, and who might be a good candidate, and what to expect with that?
Yes, of course. Focal therapy relies on a concept that the prostate cancer, even though it's a multifocal disease, meaning that roughly 80% of the patients are going to have more than one spot involved with cancer, the main lesion, the dominant lesion, drives all the challenge, or drives the possibility of the risk of metastatic spread, or probably in the future to die from prostate cancer. Nowadays, we are able to see what is happening inside the prostate. As I mentioned before, for example, in patients with the Gleason 6 or grade group gram prostate cancer, that is just a number. We not rely just in that number. We have to ask an MRI and confirmatory biopsy. The same concept plays a role here. For focal therapy, we have to be completely sure that the patient has that dominant lesion. The way that we achieve that is with mainly three things. First, an MRI. The MRI shows anatomical information plus functionality information, how the water travels through the prostate, so we can identify lesions that is susceptible to be called like a high grade of significant lesions. Then we do a biopsy, and there's mainly two approaches: transrectal through the rectum, and transperineal between the place between the legs behind the scrotum. Nowadays, we prefer the transperineal approach mainly because, as I mentioned, since we play like a confirmatory biopsy, we try to reduce the risk of infection. And the third probably tool that we're going to use is genomics. We see different patients, and one of the setting of the patient that we see is a Gleason 6 with high volume. So we not rely only in histological, what we see in the microscope. We want to see the molecular, the biology that comes from the DNA or RNA of that tumor. So if you have patients with high volume Gleason 6 or grade group gram, probably the genomics is going to play a role. With that, we can deliver the energy to the exact, in a pinpoint fashion, just with the lesion that I mentioned. The way the energy that we use is the high intensity focused ultrasound, the same ultrasound that probably your partner, your wife, used to see the baby. But if you deliver just in a pinpoint fashion, it's able to destroy in very precise manner just the lesion that is involved with the cancer.
Thank you very much, Dr. Olivares. I'll also make I just see that Dr. Kayuk has joined us. Dr. Kayuk, we were just discussing focal therapy, so it might be a good moment for you to, if you'd like, possibly discuss the surgical options for focal therapy being sort of developed these days.
Yeah, thank you, Dr. Wood. I'm excited to join this forum today with all our patients and attendee on the webcast. It's an exciting time now in medicine with all the new advancements and different options. Patients with a certain disease like prostate cancer used to have one or two options, and now you can see a drop list that is getting longer and longer. Prostate cancer treatment, surgical treatment remains, kind of confusing to many people because you read on the internet and you can see all different directions. For the focal therapy, that means you are not removing the entire gland, you are only targeting part of the gland. Of course, there will be still a risk of cancer in what you leave in, but the trade-off is that it's done in a less invasive way, and that is preserving the functional outcome. So in terms of the best cancer control, it's still treatment of the entire gland being removed. But for that, patient may have risk of incontinence or risk of impotence. The incontinence part is minimal, and that surgery have improved so much, such that at 6-month follow-up, patients enjoy at least 95% continence rate. For potency, however, the general number is somewhere between 70 and 80% will get their erections back in a year of follow-up. That's why focal therapy started. And that is, how about for those who are not very high risk of having the cancer progression? We treat that target lesion, as Dr. Oliveris was saying, and by that the trade-off would be more secure outcomes in terms of potency and urine control. Focal therapy is effective, but also have some exclusion criteria. Exclusion mean patients may not be eligible because of certain criteria, like very large prostate, location of the tumor itself, previous surgery to the prostate, calcifications, and so on. For these indications, we start thinking of what can we do for these patients who would be eligible for a focal treatment and yet not eligible for the focal therapy that Dr. Oliveris talked about. And with that, we developed a surgery where we go in and cut part of the prostate, half of the prostate, the cancerous part, and leave the good part in place. This is still early on. We've done only a small number of cases so far with great success. And that's because the surgery itself, the morbidity of the surgery itself, have decreased so much that we send patients home same day in 90% of these surgeries. So we're very excited that we can give the patients options. You can ablate it, you can excise it, and reach the good outcome for the patient.
Fantastic. Thank you very much, Dr. Kayuk. That was fantastic. There's a couple questions here about some specific scenarios, but I think are worth discussing. In a patient with a very large prostate, maybe I can give this to you, Dr. Haywood. Around 170 grams. How would the size with prostate cancer? How would the size of the prostate affect decision making with regards to radical treatment options?
Sure. So having a big prostate, is something that we definitely encounter. When I'm counseling these men with a very large prostate, one of the things that's important to get a sense of is their baseline, urinary function. So many men that have a prostate that's that large may have some pre-existing urinary issues related to that. So they may be getting up at night, may have urinary frequency, urgency, that sort of thing. And so in men with very large prostates, in general, the brachytherapy or seeds tends to be more difficult to deliver. Depending on the provider, some say over about 60 grams that it's very hard to do. But in general, larger prostates are harder to do with the seeds or the brachytherapy. In addition, we think that patients with the very large prostates, even the external beam radiation, can cause some more difficulties. Now, that's unfortunately not a blanket statement. There are some men with large prostates that may do well, but on the whole, tend to think that they might not do as well with radiation. In which case, as far as whole gland treatments, surgery tends to be an option for them. The other thing I'll add is that for men that have low risk cancer and a very large prostate, an option that's out there is to do, active surveillance as well as a bladder outlet procedure like a TURP or like another procedure to open up the prostate and let those men urinate easier. So there's a lot of options out there for those men.
Thank you very much, Dr. Haywood. There was a couple pre-submitted questions regarding the topic of ordering, the order of surgery versus radiation first, and if you need one, if you're going to need both, which one would you want first, or if there's any difference between doing radiation first and then surgery, or surgery first and then radiation. And Dr. Kayuk, would you mind just discussing how it sort of may or may not change the surgery, whether radiation happens first, and how that may or may not change the outcomes the patients can expect?
Sure, thank you. So for the example you gave, the 170-gram very large prostate, radiation may be tricky. And that's because the larger the gland, the more you need to cover with the radiation. And after the initial treatment, the prostate may swell a little bit, and that can block the urine for some time. And the way around it is to give hormonal therapy for some time to shrink the prostate and then go for the radiation. Alternatively, for surgery, we do not need the hormonal therapy, and we do not worry about blockage of the urine immediately after the surgery because you're removing the gland. However, in surgery, the larger the prostate, the more complex the procedure would be, and the requirement for expertise by the surgeon and the surgical team would be because, larger gland mean it occupies more space in the patient, and you need to navigate around it with the instruments to get it out. So does this answer your question, or you were alluding to something else?
No, I think I was just alluding to the fact that oftentimes, just to summarize what you're saying, and this can be made more complicated by the size of the prostate gland, but oftentimes after radiation, doing a prostatectomy is more difficult and requires more technical expertise, and often is associated with higher rates of various complications postoperatively versus doing the other way around and doing a prostatectomy first and doing radiation afterwards if necessary. There was just a couple pre-submitted questions about that.
Dr. Wood, if I can continue a little bit on the same thought here, is that surgery after radiation, that means the radiation did not complete the job, so the patient comes with recurrence of the cancer requiring surgery. That's called salvage prostatectomy, and it is much more complicated because of the scar tissue that will be around the prostate after the radiation. And the biggest impact will be on the urine control. So surgery for patients who failed radiation will suffer from incontinence much more than if they were to go for surgery without the previous radiation. On the reverse, if the patient had surgery and the cancer comes back and the patient goes for radiation, that will not impact their urine control when they get the radiation following surgery.
Yes, thank you very much, Dr. Kayuk. There's a question here within the chat, which I think plenty of patients may be curious about, and that's the case of a persistent PSA elevation or even a PSA elevation that goes down and comes back up following radical prostatectomy or even following radiation. Dr. Olivares, could you talk a little bit about what we do to monitor patients after either radical prostatectomy or radiation, and what the different treatment options may be if the PSA comes back up?
Sure. The PSA is a protein, it's a substance that is produced by the prostate. If you remove the prostate, the level of the PSA level must drop down close to zero. The cutoff that we use is 0.2. So after the radical treatment, you must have almost undetectable level of the PSA. After the removal, you can face two options. That first, the PSA never drop off. We call persistence, meaning that 3 months after the surgery, your PSA is still higher. The way that we have to address is the possibility of have not localized disease at the moment of the surgery. So we have to run some tests to make sure that we don't have lymph node positive, or we don't have near the prostate itself, for example, the prostatic bed, you don't have still tissue that is producing the PSA. Probably the irradiation, the radiotherapy of that zone of the pelvis is going to be the right answer or the right treatment for you. The thing is that we can remove the prostate from the location that we are seeing nowadays where it is. What I'm trying to tell you that after the removal, 1 year after the surgery or further away from there, you can see that your PSA is start raising up, showing like an uptrend. And in that case, it's not like the first scenario we call now recurrence or relapsing. The first thing that we have we try to achieve is that try to see where is the exact location. For example, running different scan, the PET PSMA or the MRI, to try to catch what zone is producing the PSA. According to that information, we are gonna recommend the best treatment. If you had a recurrence or relapsing, hopefully it's in a unique spot. So we might consider the resection of the lymph nodes, probably plus radiotherapy or hormone therapy in that setting.
Yeah, thank you very much, Dr. Rivera. It definitely can be a confusing topic for patients, this concept of recurrence. And it's important to realize that there can be multiple ways to handle it. But as Dr. Rivera said, oftentimes the most important first step is determining where that recurrence is happening. So there's another interesting question here to go back to active surveillance for a moment, Dr. Haywood, about the exact sort of timings and protocols of active surveillance, and how long is sort of too long in terms of waiting in between biopsies and MRIs. And if you could just give a little bit of insight into how in your practice you tend to handle active surveillance, and whether, you know, the difference between 3 months and 6 months and a year, whether that seems to make a difference.
Sure, that's a great question. And you know, to be fair, you know, there's no kind of one active surveillance strategy that works across the U.S. You know, certain centers will develop strategies amongst themselves, but there's no one that kind of works for everybody. I can tell you kind of how we think about it here. You know, for men that are interested in active surveillance, I tend to do a repeat biopsy called a confirmatory biopsy about 6 to 12 months later with an MRI beforehand. And what I tell patients, this is my medical version of the measure twice, cut once you may have heard while you're building things. And the idea is that before we fully commit to this idea of active surveillance, we want to double check and make sure that we haven't missed anything, you know, that might be more aggressive. Assuming that confirms their eligibility for active surveillance, I tend to check a PSA and a digital rectal exam of the prostate in the office every 6 months, and then I tend to get an MRI about every year to a year and a half, depending on their PSA trends, and tend to do a biopsy about every 2 years. But certainly, as we acquire more evidence, you know, there are some patients for whom we spread out those biopsies over time if they have very well documented stability of their cancer. So, if, for example, if we've done, you know, 3 biopsies of a man and it's always been, you know, very low grade and his PSA is not changing and then MRI is not changing, we may spread it out to say every 3 years or so, just to save some of the additional risks and discomfort of a biopsy.
Fantastic. Yeah, thank you, Dr. Haywood. So, Dr. Oliveira, there's a 1 or 2 questions here that I think probably you have a pretty unique expertise to answer. So the first is we have a couple patients asking about the new biopsy techniques of the transperineal versus transrectal that have been briefly mentioned so far, and you know what was the reasoning for the development of the transperineal, and what might be some of the advantages to that approach.
Because the location of the prostate, there's two approach that we can use to place a needle and take tissue and then see to them in the microscope. The first is through the rectum. That's why your urologists feel the prostate through the rectum because it's pretty close. The problem with that is the risk of infection. And actually, it's not directly involved with the use of antibiotics or the cleaning solutions because the bowel produces bacteria, but the bacteria must stay in the bowel area that we plays an important role, in absorbing nutrients and producing some gas that is important for the daily living. The problem with that bacteria is in the prostate and can develop infection. And sometimes that infection is pretty important, pretty aggressive, pretty heavy, so it can deliver to a sepsis, like a whole response of your body because that infection. Having that in mind, in the recent years, we are more to a transperineal approach. The perineal area is the area between your legs, behind the scrotum, between the scrotum and the anus. We can access through the needle, and we use to that two visualization. One is your urologist that is going to be seated in front of you so we can see where we place the needle. But at the same time, we place a probe through the rectum to see how deep the needle must go. With that, we can achieve a better sampling, especially in the anterior part of the prostate. Posterior means through the rectum when you feel the prostate. Anterior is towards the belly of the patient. It's not easy to go through the rectum. It can be done. I'm just telling you that it's not easy to go from the rectum towards the anterior part of the prostate. With the transperineal approach, you have access of almost every area of the prostate with the reduced risk of infection. I just want to point out the fact that even though the risk of having infection is lower, it's not zero. So we have to always pay attention of chills or fever after the biopsy.
Okay, thank you very much, Dr. Alvarez. And just because there's one other question I think you'd be uniquely qualified to answer, and that's we have a question regarding the differences in different ablation therapy technologies available, and either ultrasound or laser, which I think it probably is a reference to irreversible electroporation, and what the pluses and minuses might be between those two approaches as they both sort of gain further clinical experience.
The focal therapy, again, the focal destruction or ablation of the cancerous lesion relies on use of energy. The more widespread knowledge comes from the thermal energy, meaning freezing, we call cryotherapy, or heating up, we call high-intensity focused ultrasound or HIFU. That relies in the fact that we place a probe in the case of HIFU, which can pinpoint the liver energy produce coagulative necrosis. That comes from if you heat too much the tissue, it's going to destroy, and the water that is inside the cell, it's going to start like a boiling, destroying the cell, producing necrosis. That is the death tissue that comes from ablation. But it's not the only source that we can use for focal therapy. There are actually very exciting news from nanoknife or electroporation that relies in a different concept. And it's mainly the current, the electrical current between 2 or 3 dots. If you do that, the membrane potential, that means every cell has a different potential, meaning positive and negative charge that allows the cells to live. If you change that potential, the cells develop like small holes and there is a death of that tissue. We have more experience and more knowledge using the thermal energy. But in the near future, I think we're going to see more and more data that comes from no thermal energy. And for now, the functional and short-term oncological outcome looks pretty promising.
Thank you very much, Dr. Oliveira. It's very informative. Dr. Haywood, there's a question here regarding something that we mentioned once already, which is PSMA PET scans, and how they've changed practice, and in particular how accurate they may be, and the possibility of false positives. And maybe talk a little bit, if you could, about how accurate PSMA PET is and how it's changed prostate cancer care, and even how that might depend on PSA a little bit.
Sure. Yeah, I'll cover this one a bit briefly because we haven't used it much, at least in our clinical practice, for treatment. So PSMA is a newer PET scan that's targeting a molecule called PSMA, which is on prostate cancer cells. And so the idea is that this is going to be a more accurate way to find where prostate cancer cells are. We've used it, very well in the post-treatment setting. So like men that have had either prostatectomy or radiation before and now have a rising PSA, we've used it to help pinpoint where there may be some areas outside the prostate to help us determine what the treatment strategy is. There's a lot of interest in using it before treatment. So for example, if you have a man who has a very high risk cancer, where they would have a higher risk than normal of having metastatic disease, if you did this before you were to do, say, a prostatectomy, you might determine that there might already be, some spread of the lymph nodes, and that would help change your management accordingly. I will be honest that I have not had very good luck using those in the pre-treatment setting, mostly because insurance hasn't covered them. And so our experience with those has mostly been experimental. To the question of false positives, I don't know the rate of false positives off the top of my head. I know there are probably some false positives, but in our experience in the post-treatment setting, that they have been fairly accurate.
Dr. Good, did you let me?
Of course, go ahead, Dr. Lars.
One of Dr. Haywood said that I just want to highlight that other utility that the PSMA PET scans has is sometimes we face patients with highly risk of having prostate cancer because the family history, that is a very important factor. The PSA is pretty high, but I already have an MRI that probably it's negative. In that setting, we can use PSMA PET CT to try to localize within the prostate where is the area that is concerning for cancer. At Cleveland Clinic, we also have experience using the PSMA information for the screening purpose. For sure, it's not the more known indication, it's coverage and insurance part involved, but just for academic purpose, I just want to highlight that we can use that information in patients with highly suspicious of prostate cancer with MRI invisible or negative before the biopsy.
Yeah, thank you very much, Dr. Oliveras. I just wanted to reiterate that PSMA PET PET scan is definitely a new modality, and as you've heard from Dr. Haywood and Dr. Oliveras, the implications and the uses of PSMA PET are really just starting to be fully understood. It's certainly going to be a useful tool for urologists, and we probably don't know even now all the uses that it may have in 10 years, for example. Dr. Kayuk, we have a question here regarding the possible morbidity associated with repeated prostate biopsies over many years as a part of an active surveillance protocol. Can you speak a little bit about, what, if any, damage that may cause to the prostate, or any morbidity from the biopsies, and maybe how that might compare to the morbidity associated with radical treatments?
Right. The most common way to do a prostate biopsy have been going through the rectum, and that repetitively can cause scar tissue that goes between the prostate and the rectum. So if the patient would one day elect to go for surgery, that is exactly where the surgery will go to separate the prostate from the rectum, and scar tissue can complicate that area. That's the most common, challenge in the surgery post multiple biopsies. During the biopsy itself, obviously bleeding or infection can be a immediate complication that happen, shortly after the biopsy itself. These have been decreased by going through the transperineal approach. That means passing the needle from the skin between the legs behind the scrotum straight to the prostate, rather than the needle going from the rectum to the prostate.
Yeah, thank you very much, Dr. Kayuk. I'm just gonna, as we get closer to the end of the discussion here, I just want to again encourage everyone, if they have any additional questions, any questions that are holding out, to continue to share them. I just wanted to just advance the slide as well, so that I mention this so that I don't forget. If you're looking for additional information, this is the place to get it. clevelandclinic.org/prostate cancer care will answer a lot of questions that we may not have had time to get to today. There's a phone number here that you can call to make an appointment with any of our prostate cancer experts, and then there's an email address as well to get any further questions answered.
Dr. Wood, if you can spare a minute here just to also introduce one new approach that we are very excited, since we are listing so many approaches here for treating the prostate cancer. And this is based on a new generation of robot, a robot that does not require multiple arms to make multiple cuts and get into the prostate. Now there is a new generation robot that looks like a cannula, just a cannula from which the instruments will come in. So we make one cut in the patient, and we get the robot straight into the bladder of the patient, not through the whole belly, just inside the bladder, to do the surgery that we were discussing earlier today. And the benefits from that have been very promising. We send the patients home typically within 4 hours after surgery. We keep the Foley catheter for half the time the standard way. That's only for about 3 to 4 days. And we found that the time to continence have been shortened significantly, where almost half of the patient will not require pads after the surgery. So we're very excited. The only challenge is that that's not offered to all comers. So this are for selected cases, patients who don't have an advanced disease or aggressive disease, cancer that's localized to the prostate, in a prostate that's not very large, definitely within about 50, 60 grams in size. So we're excited about this modality also, that also can custom make the approach for our patients. So previously we used to have only 1 or 2 options, and now the list is big, so we can pick and choose what fits the patients and give them the best outcomes and meet their goals and control the disease.
Thank you very much, Dr. Kayuk. And I just want to piggyback on that by just reiterating that's something that's really important to anyone who's taking care of patients with prostate cancer, is the balance between the benefits of longevity and reduction in symptoms, as well as minimization of the postoperative morbidity and different side effects from the procedure. And so single port radical prostatectomy, as Dr. Kayuk is mentioning, is another very powerful tool to try to reduce that morbidity from the procedure. I think we have time for probably one more question. And I'll give it to you, Dr. Haywood, if I could. And it's something that has come up a few times with a few different patients throughout the live chat. And it has to do with proton therapy or CyberKnife, and what the different sort of radiation modalities, what the differences may be, maybe in terms of number of cycles or duration. And I think probably the question that we're getting the most is whether there's any proven benefits in terms of morbidity, just from your understanding for the different modalities.
Sure, I think that's a great question, because there's, as patients are out there looking, there's a ton of advertising for both of the CyberKnife and the proton and all that. The the genesis of this, and as we kind of go back to where I talked about the overview of radiation options, is that it's very difficult to precisely get the radiation 100% to the prostate. And so that's where a lot of the side effects come about, where the radiation is absorbed by either the bladder or the rectum. And so, the proton and the cyberknife and those other types of radiation were developed with that idea in mind, of coming up with ways to deliver the radiation energy more accurately to the prostate. And they have their theoretical benefit of doing that. To my knowledge, and I will admit that I don't stay as current on the radiation literature as I do on the surgery, but to my knowledge, there hasn't been proven to be a significant benefit of these modalities over kind of conventional, radiation therapies. Especially with the improvements they made in conventional radiation, like the SBRT, or the stereotactic body radiation therapy. They can deliver these things very, very precisely. So you'll see there's a lot of advertising out there about it, and I think patients definitely like what the claims are. I'm just not aware of any good data that it's proven to be that much better.
Yeah, thank you very much, and I'll at least second that from my perspective, that I'm also not aware of any good quality data that's come out that's shown substantial differences between the different radiation modalities. But as Dr. Haywood said, we are not radiation oncologists. So I'd like to just thank all the audience participants, and also thank the panelists for their time and for a tremendous conversation. I know that there's a tremendous amount of confusion and a lot of questions regarding all aspects of prostate cancer, but definitely for different management options for localized prostate cancer care. And if you have any further questions, I really encourage you. There's a lot of very specific questions in the chat, and we didn't get the chance to get to all of them, and I apologize for that. But really, the best way to talk about specific scenarios with localized prostate cancer care is to make an appointment with a prostate cancer expert and talk to your doctor about it one-on-one. And I also encourage all participants to attend the remaining two Prostate Cancer Awareness Month virtual series lectures over the course of the next 2 days. And of course, again, any further questions, you can visit clevelandclinic.org/prostatecancercare, call to make an appointment, or email any questions to the guki@ccf.org. And thanks again, everybody.
Thank you.